Viruses and cancer. By the end of this lecture, you will be able to list the 7 human tumour viruses and their cancer. Describe the common features and key differences of human tumour viruses. Discuss the importance of viral latency, viral oncogenes and immune evasion on the tumorigenic process. Describe the effect the AIDS pandemic had on Kaposi's sarcoma incidence, whilst understanding that HIV is not a tumour virus itself, and understand that virus infection alone is not sufficient to cause cancer. Around 15 to 20% of global cancer incidence is attributed to an infectious agent, be that a virus or bacteria. There are 7 known human tumour viruses, 2 RNA and 5 DNA. The 2 RNA tumour viruses are human T lymphotropic virus 1 or HTLV1, which is linked to adult T-cell leukemia, and hepatitis C virus or HCV, which is linked to hepatocellular carcinoma or liver cancer. Amongst the 5 DNA tumour viruses is Epstein-Barr virus or EBV, which was the first human tumour virus to be identified in 1964 on the basis of its association with Burkitt's lymphoma. EBV is also associated with Hodgkin's lymphoma, nasopharyngeal carcinoma, and some gastric cancers. The other 4 DNA tumour viruses are hepatitis B virus or HBV, which is linked to liver cancer as well, human papillomaviruses HPV 16 and 18, which are associated with cervical cancer, Kaposi's sarcoma herpes virus or KSHV, which causes Kaposi's sarcoma, a cancer which exploded onto the scene in the late 80s during the AIDS pandemic in the States, and finally Merkel cell polyomavirus or MCV, which was the most recently discovered human tumour virus and is linked to Merkel cell carcinoma, a form of skin cancer. Tumour viruses share a number of common features. The first is that they can be classified as either direct carcinogens or indirect carcinogens. If the virus expresses a viral oncogene, then it can be categorized as a direct carcinogen because the viral oncogene itself directly causes cancer. On the other hand, if the virus or bacteria stimulates chronic inflammation, which, as we know, is already a hallmark of cancer itself, then it can be categorized as an indirect carcinogen. Another common feature that all tumour viruses possess is that they persist in the host as a latent or pseudo-latent infection. That is, they effectively are dormant or they go to sleep. In so doing, it can evade the body's normal antiviral immune response because latently infected cells express only a small number of cell surface antigens which the immune response uses to recognize foreign objects or damaged cells, thereby eliminating them. Tumour viruses often encode a viral oncogene, which is similar to a normal cellular gene, but is often altered in such a way that the signalling pathways it activates are inappropriately stimulated, sometimes constitutively, i.e. all the time. In order to survive, a viral oncogene will often target some of the tumour suppressor signalling pathways to avoid immune destruction, which prolongs the life of the cell and allows the virus to mature properly. Inadvertently, this directly causes cancer by increasing the risk of cellular transformation, and this is known as the anti-antivirus hypothesis. Much of what we've learned about tumour viruses comes from experiences from public health issues, the most prominent of which is the AIDS pandemic in the 80s. People who were immunocompromised, such as AIDS patients or transplant recipients taking immunosuppressant drugs to prevent transplant rejection, are at a much greater risk of developing cancer, and the majority of cancers that arise in these populations are virus-associated cancers. For example, with the onset of the AIDS pandemic, there was a profound increase in the incidence of Kaposi's sarcoma, which was inadvertently reversed by giving highly active retroviral therapy. So in other words, by reducing the viral burden, the cancers were also reduced. It's important to remember, however, that virus infection alone is not sufficient to cause cancer. Cancer is a multi-step process that is caused by numerous environmental, genetic, and dietary factors.